Shweta. I think we had a discussion about the machine and maybe if I'm not wrong, how the machine makes a slight difference. So no financial disclosure, but I'll just take you through the impact of FOVEA BMO center and the anatomical positioning system, which is more like a GPS for this particular technology. So to start off, I think you would have all seen the animations of ILM getting mapped, the Brooks membrane opening getting mapped, and what is the BMO MRW. I think we have all covered about the Brooks membrane opening minimum rim width. So let us see something more as to why this is more important. So this is a glaucoma module premium edition, as the Spectralis would like to label it. And I'm going to take you through this particular boxes here where it's more of an anatomical orientation as to how RP is over BM and the BM is over choroid and the choroid is over sclera. So this GMP actually has an anatomical positioning system, because today we are more dependent on GPS. It's still debatable, as we had quite a good debate now. But this GPS, what it gives you an extra edge is, if there is an eye movement with a single beam, we are not able to track the eye movement. But with a dual beam, you can see that even if there is an eye movement, the tracking is actually very meticulously done. So that is one advantage with this, because same piece of tissue is examined today, 1 year later, and even 2 years later, or whenever we have the follow-up, because of the dual beam live tracking. So again, you can see this is how the animation is done, and in reality you can see, however the eye has a micro movement, the same piece of tissue examines, and papers have shown less than 1 micrometer difference between two readings taken maybe on the same day, slightly apart. So the variability is quite minimal, and 16 scans per second is what the machine has to offer. So technology wise, still no financial disclosure, but this is what it really gives. So first it plots the center of the fovea, and then it plots the center of the Brooks membrane opening, and then this center and this center is matched with the fovea BMO axis, called the FO-BMO axis. So once that is plotted only, now the next curves are centered on this. The Brooks membrane opening minimum rim width is now centered on this, and then you can see the RNFL and the ganglion cell inner plexiform layer orienting itself after the fovea BMO axis is plotted. So that is the unique feature of this particular APS. So this is a patient whose head position is normal. The same patient, when the head is slightly tilted, you can see the superior temporal area goes in for a slight thinning. It actually confuses us. Where you can see the fovea, which is actually down, is now seen as if the fovea is on top. But that's not the reality. So this is what happens when the patient has a tilt or a cyclotorsion. But the same patient, head is in normal position. With this technology, even when it is tilted, you can see that 140, 142. So that is the particular fovea BMO axis, or the APS plotting this particular thing does, which is quite actually very useful. So the impact of fovea BMO axis is, you can see, this is a +6 and this is a -7. What does it mean is, if this patient is just plotted without the rotation, it is actually wrong, because the fovea is actually slightly situated up, and here it is down in -17. So this is wrong if you don't rotate it. Only if you rotate a clockwise rotation for a fovea which is situated on top, and for a fovea which is situated on bottom, the machine slightly rotates it anti-clockwise. So thereby slicing it from the center of the fovea to the center of the optic nerve. So that is very important, and that's where this kind of reporting, and it also generates a Hood report. So we also have a visual fields in the next session, where you can also join with us, where we'll be talking about the correlation of this. You can see, since the same piece of tissue is examined, I think from 2019 to 2020, this patient is having a control of IOP, and I'm thinking he's actually improving in his target IOP, but in reality, I'm just able to sense there is a mild progression of his glaucomatous defects. So these things are only possible if we examine the same piece of tissue. Just by getting the IOP under control doesn't mean the patient is not progressing. So these kind of reports in this OCT gives me an eye-opener that I'm still not on the right plane, I have to do something more. And this is one of our papers which we have published in the Indian Journal of Ophthalmology, me along with my mentor, Dr. Satyan sir. I would like to thank him at this moment, because he's been the one who has taught me A to Z in glaucoma, and he's being here with me. Thank you once again, sir. And without much time, I'll move to the next part of the talk, which is just a 2 minutes one. Confounding factors. So we saw about the fovea BMO axis. So what it is actually capable of. So in fovea BMO axis, now we'll move to talking confounding factors. Red disease. What happens when we have a myopia? What happens when we have another disc which is quite tilted? So God has given us this kind of a thing, that we don't have the same optic disc. There is a huge variable of optic disc that is available. Again, I am reorienting you to this basics where RP is blue, Brooks membrane is red, choroid is yellow, and sclera is green. So what are the alpha, beta, and gamma zones? This is a very, very important point that we need to know in our post-graduation fellowship. This keeps coming back and back. So what we think in reality is we see the optic disc margin as the end of the sclera, Elsning ring. But in reality, it is not that. There is a slight difference, the red line. The red line is what is the ending of the Brooks membrane. That is the real definition of where the OCT is getting terminated, the termination of Brooks membrane. So there is a slight change in concept that what we see in our fundus is not what it actually is. The true margin is actually the Brooks membrane, and Chavan et al. Has proved it in his paper. So now, categorizing the ideal situation. In an ideal patient, when the BMO margin that we saw matches the clinical disc margin. So usually we would want the BMO margin to match the clinical disc margin, and there will be no hyperreflectance surrounding the optic nerve head. So this is how it will look. But what happens when the BMO margin that we see in the OCT that doesn't match with the clinical margin that we see in the fundus? That time what happens is we get an hyperreflective surrounding the optic nerve head. So this is where the tricky part sets in. So when this comes in, we have peripapillary atrophy, we have conus temporalis, and PPA and conus temporalis. So I'll just give you 3 slides and what these 3 are, and we'll end the discussion. So how to categorize this hyperreflectance? So we have alpha zone, beta zone, and gamma zone. Alpha zone, BM is present and irregular RPE is present. In beta zone, only the Brooks membrane is present. So that means in alpha zone, we have this RPE and the Brooks membrane. And in beta zone, we only have the Brooks membrane. In gamma zone, no Brooks membrane and no RPE. We'll have only the choroid and sclera. Now peripapillary atrophy, you can see the RPE ends here, but the BMO comes up to here. So I have made this slide here on top. RPE ends, but then the BM, choroid and sclera continues up till here. So now what happens is this area is the hyperreflectance area in peripapillary atrophy, this particular area here. So again you can see. So due to the temporal RPE absence, in this area the RPE is absent. So more light reaches the underlying structures, so they appear hyperreflective. So this is that area. And this is the alpha and this is the beta. So now we can see, again I'll just show you this. So the hyperreflectance area is this area because the RPE ends, here itself the RPE ends, and this area is the hyperreflectance area. Moving to conus temporalis. In conus temporalis, RPE, Brooks membrane, and choroid end at here, and the sclera continues. So in conus temporalis, you can see the sclera alone continuing. So this is what we see like a temporal myopic crescent here, and that is the RPE and Brooks membrane end together at this point, and then the hyperreflectance is seen here. So that is where the absence of RPE and choroid at this area enables a direct view on the sclera, and therefore a white sharp demarcated hyperreflective zone gamma. So this is the zone gamma where there is no RPE, no Brooks membrane and no choroid. This is the gamma zone. So this is conus temporalis. What happens when conus temporalis and peripapillary atrophy are present together? So see on top, first the RPE ends abruptly, then the Brooks membrane and choroid end together, and then the sclera comes out. So this is quite a complex phenomenon which gives us a lot of nightmares because you see the real margin is in between the hyperreflectance zone. So you can see this is where the real margin is present. In the previous cases, we don't have that confusion, but here, where the Brooks membrane ends, that is where the hyperreflectance zones are present. So the RP ends here, the sclera ends here, but the Brooks membrane is in between them both. So there, the hyperreflectance region, in the center of the hyperreflectance region, we'll have the Brooks membrane. So this is alpha, this is beta, and then this is the gamma zone. So when our conus temporalis and a PPA are together, we have the alpha zone, the beta zone, and the gamma zone. So with that, I'm ending the 2 talks, and I thank Shweta for the opportunity. And once again, I thank my mentor for giving me the knowledge and wisdom on glaucoma toolkit. Thank you for all the attendees. Thank you.